during our first presentation, as also as we've talked about sort of this legacy of the war on drugs during our last session, there have been some elements of harm reduction, because I think as we'll learn a little bit more about today, as a social movement, recognition of sort of the gray area of drug classification, especially when we talk about like the criminalization or the morality of drug use, is really, really core to sort of understanding harm reduction approaches. And so we're going to talk a little bit about just sort of the core principles of harm reduction today, and then ways that some agencies, organizations, communities are incorporating harm reduction. And then I'm hoping Patrick and I have put together some really, I think, good discussion questions to really get at the meat of some of these larger ethical questions with harm reduction, and also some of the barriers or facilitators in implementing harm reduction interventions in states like Nebraska that haven't quite gotten there, but still, I think ripe with a lot of opportunity too. So, I think I've thrown a lot of slides out like this, right? Harm reduction as just if we were to look it up in Merriam-Webster dictionary, it's just really the reduction of harms generally, right? I think what we'll learn though today is that that's been picked up a lot within the sort of social movement context as well. But you think about it, it's really the things that we do throughout our daily lives that are going to be making ourselves safer, right? Ideally, we're going to be throwing on a little bit of 15 SPF, maybe not right now in Nebraska, I understand, but over here in Colorado, it's definitely necessary. But seatbelts, taking a taxi after a night of drinking, all these different things that we can do to reduce the harms, both like physically, but also reducing harms criminally as well. Like I'm not going to drive drunk, so doing things like that, calling an Uber, taking a taxi. But just at a pure definition, right? So harm reduction as a sort of public health intervention can be defined as a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. But really what we've seen in the last 40 years is this massive growth into a social movement, right? And we see is that a lot of harm reduction spaces, can't really operate without this sort of core philosophy that harm reduction is a movement for social justice built on a belief in and respect for the rights of people who use drugs. And I think the way we can interpret this as well is essentially, an individual's drug use should not determine the level of care that they're receiving in either a social service or a medical setting. And it shouldn't determine whether they're actually going to be cared for or not. And I think that we've seen, especially in the last 40 years, we look at the HIV epidemic is people due to perceived behaviors being treated less than in a lot of these settings. So just jumping in briefly to harm reduction as a social movement is sort of asking these questions about, the issue of drug use, right? Is this a moral issue? Is this somebody a moral failure because they have a substance use disorder, or they are just using drugs more generally, don't have a substance use disorder? Is this a medical issue? We see this with the sort of brain disease model of addiction. We see this, sort of quasi, I don't want to say pseudoscience treatment industry, because there's evidence for sure, I think, demonstrating some of the effectiveness of a lot of these interventions. But it does enter sort of a quasi-medical sphere, especially when we talk about like detoxing and abstinence and these types of things that may not have better or a proven sort of long-term outcomes that we would see with other types of interventions and things like that. And so, but also seeing this as a social issue, why are people using drugs in the first place? Do we have to address some of these undercurrent social determinants of health, things like that, beneath all this drug use as well? Also, we're recognizing that if I am a Black trans woman who uses drugs, I'm going to be experiencing stigma, discrimination in our systems more than like a white cisgender man who uses drugs, right? And so understanding that there are going to be levels of impact of the war on drugs, of drug use, and how people are also treated in our medical systems. We see studies that demonstrate that, for example, like African American people are seen to have, especially by some medical professionals, seen to have like a higher pain threshold. So people are withholding pain medication, things like that in medical settings. So all of this is sort of, fusing together with understanding this sort of layered type of stigma amongst a lot of people. We also see with the limitations of professionalization that, if I am going in as a Department of Health individual with a badge that has the state of Nebraska or the state of Iowa on it, when I'm trying to engage a person who uses drugs, I'm going to have a very, very different experience if I'm a person who also admits and opens up about their own drug use and is able to sort of approach this individual from more of a peer perspective. We can talk a little bit more about that too in the discussion section. But understanding that a lot of the systems we have in place, whether we're talking about health departments or like Department of Human Service offices, things like that, are not going to always be able to meet people where they're at, right? And so meeting people where they're at, another mantra that we use is nothing about us without us. And it's so essential that as we're creating programming, and as part of the social movement, as we're creating programs for people, that we include people who are affected by these programs in the planning process, right? And so what we've seen is sort of this rise of like drug user unions to unionize people who use drugs to advocate for better health services and other social services available, things like that. And so we can talk about that more during the discussion section. But all of this, as we talked about in our last session, is a response to sort of the consequences of the war on drugs and viewing drug use as a whole as a sort of a criminal act, right? So briefly, and this is actually from a really, really good paper that I recommend you all, from several really big harm reduction leaders. Monique Tula, who is the head of the National Harm Reduction Coalition, was one of the co-authors on this, but really defining these principles of harm reduction, right? And so there are 6 principles that can, I think, be applied beyond drug use and potentially sex work as well, and other sort of areas. And so the 6 principles are humanism first, and this is just really identifying that providers value care for respect and dignify patients as individuals first, right? Like pragmatism, I love this one. None of us will ever achieve perfect health behaviors. Whenever I'm in a group, and actually I think I asked this during our first session, how many people like believe that exercising like 5 times a week is a good idea. Most often than not, most people are not exercising at like sort of the optimal level of exercise, right? And so none of us are actually achieving perfect health behaviors out there, or most of us aren't, rather. But understanding that we're all human, right? And that we are, there are so many different drivers into affecting how we are going about our own health. Individualism, this is a big one when we're especially talking with systems. Every person presents with their own needs and strengths. And so, this does not work, right, in a sort of cookie cutter approach where we're diverting people who are caught with marijuana to a drug court, to substance use disorder treatment, that kind of thing, right? And so we hear all these different examples. And so, but are our systems really equipped to be able to provide that level of individual care? And that's a big question we can talk about later too. Autonomy, individuals ultimately make their own choices about medications, treatment, and health behaviors to the best of their abilities, beliefs, and priorities. Incrementalism, any positive change, we hear this a lot in the harm reduction world, any positive change is a step toward improved health, and positive change can take years, right? And understanding that people are going to take steps back, take steps forward, wherever we are seeing in sort of treatment environment. But even if it's an individual, and I always love the example, if somebody is unstably housed, they're rough sleeping, but they like to inject drugs, if that means going to the back of the toilet tank instead of the toilet bowl to get their water that they're going to be shooting with, that's a positive change, right? And so we need to award and talk about with a lot of individuals who are engaging through this sort of process, any positive change. And then accountability without termination, right? It never has made sense to me for people who are in a substance use disorder treatment setting, for those who relapse or use drugs again, that they'll get kicked out of the program. Of course, we understand that relapse and reusing is part of the whole process to stability. And so, I think it's really understanding that even if you're not making the individual steps needed on a care plan, whatever that is, that you're not going to be terminated from this type of engagement. So I'll go briefly over this, but this is something sort of borrowed from the psychedelic world and other sort of world views, looking at specifically the type of substance being used, the mindset in which an individual is using, and the physical setting in which that person is using, as sort of areas of where we can actually focus in on an individual's treatment plan, ways to make an individual safer, and just really learning a little bit more about how they're using drugs, right? And so, obviously when we're talking about treatment for somebody with methamphetamine, it's going to be hopefully a little bit different than somebody with like who's using opioids, right? And as well as marijuana or other drugs like that. We're going to have some sort of different care plan, because there might be different reasons why people are using. But we're also asking questions about frequency, the amount it's used. How is that person, what's the route of administration? How is that person using those drugs? How does the legality of the use impact how they're getting the drugs in the first place, right? And also, I think, impacting how they're testing and assuring that they're getting a safe sample of that drug. And that also feeds into the quality of the substance. Mindset, though, obviously, if I have been up for the last 5 days, have not been hydrating or eating, and then I decide to use opioids, that's going to put me at a higher risk for overdose, essentially, with some of these opioids. And so, it's looking at physical health, the state of being, like, am I using just after I've had a fight with a loved one? How is that going to impact my use? The culture around the individual and sort of, what does the culture say about this individual's use or the types of drugs being used? The stage of change that the individual is at, and this can apply to whether an individual is trying to taper down their use, moderate their use, is more interested in sort of maybe testing the limits of their use. And again, also, just like, why are they using in the first place, and how is that impacting their mindset? Setting is just really going to be that physical environment. Where are they using, with whom, stress levels of that environment, quality of the support systems available. So does this environment have a harm reduction center, for example? And then how is the society also interpreting their use? And so I think of this as well. If I am driven, if I don't have like a supervised consumption site, for example, a place where I can safely inject, I might be injecting in an alley, I might be injecting in other spaces. And how is that sort of seen by the community at large as well? So thinking about harm reduction, I think I've showed this slide before too, but just thinking about harm reduction in the public health context, we have sort of direct and indirect spaces, sort of approaches for this. And so obviously we're talking about the safer drug use, increasing sterile equipment access, pragmatic drug education, actually talking about some of the real risks and, talking openly about mixing instead of just saying no. Understanding overdose risks, potential, and also how to respond to those overdose potentialities. Talking about safer sex, so talking about this risk behavior cascade. A receptive oral sex is going to be potentially less. There's going to be less of a risk of transmitting HIV from oral sex versus like receptive anal sex. And also, how can we find ways to reduce sex-based violence, especially among sex workers who are very, very ostracized from most communities? Indirect, though, it's low barrier treatment adherence. If you're not making all of your goals, you're going to understand that you're going to be able to go to a space that you'll still be able to access some of these different treatment opportunities, regardless of missteps along the way. I don't even like saying missteps, but just to sort of keep in the treatment context. Building trust and healthy relationships is so essential. What we've seen from a lot of research going into specifically, healthcare and social service barriers amongst people who use drugs, trust of the actual institution is such a huge issue. And there's so many stories, whether somebody's individually experienced it, it's the sort of collective consciousness of this fear of providers who are going to out them to law enforcement, who are going to treat them without anesthetics, all these different things. They're not going to be, again, provided that same level of care as somebody who might not be out about their drug use. I think also another big piece is setting realistic expectations of support systems. And I always like to say the systemic harm reduction. Our systems are not perfect. There's a lot of bad apples in every state, every community. And just, I think, due to the decades and decades of discrimination and stigma against people who use drugs. And so giving people realistic expectations of the type of supports that they're going to get is another really big piece of the care navigation aspect of harm reduction. And of course, staying trauma informed. I think that's a huge piece, especially in the harm reduction world. And we can do a whole presentation on that too. But real briefly, since I am kind of rambling a little bit. So the really brief history of harm reduction, and Patrick and I were actually talking about a little bit about this, where I'd love to talk about this in discussion, where, potentially harm reduction has been around for centuries, right? The actual providing of tools and advice or guidance to like prevent like a hangover or something. I can even think like a millennia ago. I could imagine that being around, but we don't have a lot of documentation of that type of thing. So what we do see, like really around 1978, 1979 was the first sort of documented group of people who were using drugs. This is in Amsterdam, who called themselves the Junkiebanden, which I love that name. but really it was just a group of people, this is pre-HIV epidemic, who were just coming together to talk about how to use drugs more safely, getting safer supplies and things like that. But what we see then in specifically like Central Western Europe, later in like the Pacific Northwest of New York City, is the rise of these needle exchange programs, completely like local funded by the individuals who were providing the syringes. There were no organizations or foundations or governments that were funding these organizations at the time. And so the individual actually there is his name is Dave Purchase, and he was sort of seen as the father of harm reduction in a lot of ways in America. But interestingly, you know, so we see the massive rise in the public health intervention of needle exchange driven by the AIDS epidemic, right? And so today we probably see on average in most developed countries, I don't like to say developed countries, but countries that are at a certain level of GDP, if you understand what I mean, are that a lot of these programs, you know, were not, obviously the idea of like drug user collectivization was sort of growing in a lot of these spaces, but the AIDS epidemic really pushed through this idea that, you know, I think on average, a lot of these countries were seeing around 20 to 30% of their new HIV cases amongst people who are injecting drugs. Because of these needle exchange programs, they've dropped mostly to around 2 to 3% in most states of new infections of HIV amongst who are attributed to people who are injecting drugs. Interestingly, we actually see, if we look at like Russia, for example, it's one of the only countries in the world that the majority of new infections are due to people who are injecting drugs, or due to transmission amongst people who are injecting drugs. And that's because of the massive pushback against harm reduction programs, essentially. So rambling aside, I want to at least highlight the 4 pillars model. I'm not going to read you this quote on the bottom right, but it is an interesting sort of piece that Geneva, Switzerland at the time, was one of the first localities to really solidify in policy this sort of coordinated approach of treatment, enforcement, harm reduction, and also sort of this like prevention integration piece as well. And they were essentially saying that we cannot treat this like a criminal issue. People are going to continue going underground and transmitting HIV. It's in the open. We have these open air drug spaces, and we need to have spaces that we're in coordination with law enforcement, not to harass people so they feel comfortable to go to these spaces. And what we see is essentially this 4 pillars model extend beyond into all these other spaces, influencing programs like Insight in Vancouver, which is one of the first, is the first sort of official supervised consumption site in North America. And we sort of seen that sort of lead into just this year. We saw finally the passage of a program called Safe House in Philadelphia, which is the United States' first sort of official supervised consumption site that is slowly building. I want to throw in the 2016 Consolidated Appropriations Act because I like policy and I'm a little bit nerdy about it, but it was huge for the harm reduction movement in that it finally allowed the federal government dollars to be attributed or directed to harm reduction programs for all harm reduction supplies except for the needle. And they still they haven't moved forward on the needle. But this is huge, though. I mean, it can obviously, now we can divert federal dollars upon state approval to allow for peer recovery specialists, even cookers, things like that, everything except for the needle, essentially. So all these other supportive services, which makes me also, you know, I wanted to jump into a little bit about some of these other harm reduction communities, because if we can apply harm reduction principles to a lot of different areas, then we see sort of parallels in like the housing first movement, which started in the late 80s as well. And so this really just allows, in this graphic here, somebody is unstably housed or homeless, that in order for them to adhere to HIV medication, in order for them to adhere to drug treatment, if that's where they're at right now, you know, any type of stability, then housing is the most essential piece. So they have a safe space to go to, and it's providing housing regardless of substance use. And so we see still a lot of shelters that are either testing people or checking people's bags, essentially deciding that if you're a drug user, you don't deserve to be there, right? I mean, that's essentially what we're saying. And so we see the pop-up of a lot of these housing first models happen around the country as well currently since the 80s. Illicit substances as treatment, right? I know maybe Patrick will be excited about talking about this one too, but you know, we see even things like super pure heroin, and we don't really see this in the United States yet, but we see it in Denmark and Netherlands and Germany, where they're actually using heroin as essentially medication-assisted treatment, but they're just using heroin. And so we don't need the methadone, we don't need to do the other things. And so there's a little bit of buy-in. Again, a safer supply is going to reduce overdoses, and that's sort of the perspective that they're seeing there. Other approaches, incorporating psychedelics into therapy, sort of the addressing trauma through different perspectives is sort of the way that we're seeing that, and we see growth with that type of therapy. We're also seeing a little bit of a pivot to treating substance use disorder with the psychedelics too in countries outside the United States, I would say. Moderation management is totally a form of harm reduction. We don't have any moderation management therapists in Nebraska. I think the closest one is actually up in Minneapolis. But this is just an idea that individuals can taper, not taper, but find a place that is going to be a sort of moderated use for them, where they're not trying to essentially manage emotions that may lead to somebody being at a higher risk of overdose or going on these larger binges, things like that, that may present some other safety risks for that person. And then this is a whole other presentation, but I have to address it. Sex work decrim and legalization. I think harm reduction movement has really presented a response to the anti-sex trafficking movement, which I think we could talk about this again too for a while, but I think is potentially viewing and grouping sex work into the sex trafficking, anti-sex trafficking sort of rhetoric. And so trying to use an approach that I think addresses the realities of a lot of people who are doing survival sex work, that they might not have a lot of other options, or because they have a solicitation or prostitution charge on their record, that they're going to have a lot of other barriers in accessing less stigmatized employment opportunities, right? And so how do we sort of navigate that at the systems level for a lot of people who are doing that type of work? So we're almost done. But right now, this is from AMFAR, 41 states plus DC and Puerto Rico have currently certain service programs in their state. And I will say that even though this is 2020, it is very difficult to find a comprehensive graphic that is actually capturing the reality of needle exchange services. For example, if you actually look at this map, New Mexico is seen as one of the also first harm reduction leaders at the state level. And so they're not actually marked on this, interestingly. And so New Mexico, I would add Nevada and Idaho have also recently legalized needle exchange. And so this graphic specifically, though, is actually looking at the number of existing SSPs. So I'm not exactly sure how they defined it, but what we see, obviously Nebraska does not have needle exchange, Kansas or South Dakota as well, if we're looking at our neighbors. But a lot of these needle exchange programs come in sort of three different levels. It's either a fixed site, it's a mobile site, which is going to be usually in a van and actually driving and delivering, or it's going to be sort of a combination of delivery or networking with people who are injecting drugs. And so we see all different types of these. And so when we say syringe service program, it can mean a lot of different things. I just like to point that out. I think the most important thing, as we've sort of highlighted, though, is these programs' role as point of care navigation, right? These programs are not just providing the needle, right, for somebody to safely inject. They're creating a space where an individual feels actually safe to come to the space, and they're not going to be judged for their drug use. And in fact, that people might be able to really talk and share experiences about their own personal drug use, and it can be this information exchange where people feel more empowered, ideally, to be able to navigate some of these systems, or have sort of care navigators help them at this fixed site, right, navigate some of these services. So criminalization so I had I had to have fake news, but criminalization is good public health practice. We know that it's not. I just really want to throw this in as a review slide. We're here in an overdose crisis, at an HIV hepatitis C crisis because of criminalization, I could argue, that people are seeking ways to use more safely, more efficiently. And as a result, potentially because of the underground nature of a lot of these drugs due to the war on drugs, are facing a lot of other health risks. So, what type of education do we want to provide as a society? Do we want to have an abstinence-based focus, or do we want to sort of reflect on the realities of drug use in the United States? So finally, I think this last slide, these are some of the things that pop up against syringe service programs, or SSPs. So these are some of the concerns I've heard from law enforcement specifically. There's not enough drug users are entering treatment, right? And really the question is, if we support this type of program, are people going to be going into treatment, right? What we found, and actually CDC has listed some really great studies that have highlighted that, participants are anywhere from 3 to 5 times more likely to enter treatment than non-participants in these programs. And again, that has to go along with the level of trust that can be developed at these programs, and as well as the sort of care navigation piece as well. Concerned about increases in drug-related crimes, and we found studies that have actually shown that crime decreases in areas where syringe service programs are, because participants are connected to these other services, these sort of wraparound services, which may be some of the reasons why they might be engaging in what we call or deem criminal activity, which is often survivable, right? People are concerned about needle stick injuries. If we're flooding the streets with needles, what's this response going to be? Or where are these needles going? But we find that when people are actually more comfortable talking about the fact that they have a needle in their pocket if they're getting searched by a police officer, that law enforcement are actually going to be less at risk while they're searching people if an individual is going to be able to be open about what's on their person, And so we see actually a reduction in needle stick injuries amongst law enforcement because of SSP implementation. Again, discarding needles on the street along with the same sort of thinking. But again, SSPs are often out collecting these needles. They're going to the areas that they know are hotspots for public injection and drug use. And they're finding ways to clean up essentially the streets of a lot of the drug use waste. And then fears of increases in HIV and hepatitis C, and as well as hepatitis B. What we see is that SSPs on average and overall, if we're looking at sort of a global level, SSPs decreased hepatitis C transmission by as much as 50%, and HIV injection rates have decreased by as much as 80% in areas with syringe service programs. So there's a lot of evidence, especially over the last 40 years, that are supporting some of these interventions.